Hello, everyone, and welcome to our series where we talk about direct specialty care. And today I have the honor and the pleasure to have invited a very, very special physician, Dr. Nguyen, that is the CEO of Pacific Point Podiatry, a direct specialty care practice located in Santa Cruz, California. Dr. Nguyen is a fellowship trained in wound healing and is board certified in foot and ankle surgery. Dr. T, as I like to call her, helps people stay active and avoid unnecessary leg amputation through a lot of education, preventative foot care, and minimally invasive surgery. She's the only minimally invasive surgeon that I've known so far. Dr. T, welcome. And once again, thank you for accepting the invitation.
Thank you for having me, Diana. I appreciate being here and sharing the platform with you. You've made some huge strides, and I saw you had an announcement on your own page about the progress you're doing with direct specialty care. So I'm excited to be part of this conversation.
We're going to start asking you a series of questions that I know that many of the direct specialty care members have, but also people that are interested in direct care and especially direct specialty care, specialists that are looking to practice direct care have. And I'm going to start with a common question. Where did you hear about direct care?
I learned about direct care through actually a private Facebook group, one of the private practices group. And somebody had talked about, let's just opt out of insurance. And I wasn't sure if it was at the time somebody who was just trying to be funny or if it was a real thing. And so I kind of started to dive down into this rabbit hole. And then I found a podiatrist who had a 100% cash practice. He's a few years ahead of me. So I knew that that had already existed for podiatrists. And then I started hearing in different Facebook groups I was part of a lot of conversations about not working with insurance. And then I finally fell into my DPC story with Dr. Marielle Conception. And when I heard about her podcast, I just started to binge throughout everyone's conversation. And that was such an amazing resource for me because it was a variety of different doctors, primary care, and specialists. And then it made me realize that this could be possible for podiatrists. And then I started looking into my own specialty to see who was actually doing it and not just doing it, but talking positively about it. And there's only a handful. And so that's how I started to hear about direct care, that it was more about the social movement than just opting out. We were trying to create changes in the system that we know we financially have no weight in. But if we could help each other one colleague at a time, that got me really excited to learn more about what it means to be a direct care specialist. And then a year or two later, I found myself in a situation where I was like, why not me? Why can't I have a practice that I love, free of insurance hassles, and doing the procedures that I want to do? So that's how I first learned about it.
That's very interesting. Every single one of us, we have a story about hearing about it, thinking about it, and then pursuing it. And every single one of us have a reason why we want to pursue direct care. Most of our reasons are common, but every single one have a reason of his own or its own that pursue direct care. And I'm going to ask you, why did you choose direct care?
I don't think we realize it when we're inside of medicine, the insurance-based practices through our residency training and moving outwards, that access to medical care is really convoluted. And I only recognized that when I stepped out and said, why can't I get on the phone with my doctor without having to go through a phone tree, a series of people before I get access to the doctor? When I worked in the wound care center at the hospital, same thing. Why why is it why is it hard for my patients to contact me directly when they encounter an urgent or emergent situation? Or why is it that when they need care, it is the doctor who's on call and not their original doctor? So every time you pass the buck on, you get more distance to your patient, and the patient does not get better faster. And so that really bothered me as somebody who took care of patients who were at high risk of amputation and even having really, a lot of them end up in dire situations or in the wrong hands, and they end up with an amputation or they end up dying or something like that. And so that the entire sequence of what I wanted to achieve for my patient to the delivery of outcome was so convoluted that it made me feel really helpless. And I didn't want to be in a situation like that. So I chose direct care because I knew I could do things faster and much more efficiently if it was just me and the patient. Whereas in the insurance-based practices, very traditional hospital setting, even in the wound care center, you have to go through prior authorizations. You have to know certain coding and billing to get paid. You have to, the patient's access was even worse because if they're trying to contact the doctor, they didn't really know who to call. So they would call the hospitalist, which would then the hospital, which would then transfer them to the wound department, which would then get processed through a series of people before I even get the information that something had happened to the patient. And that was really frustrating for me. So in that experience, although there were some great things that came from it, I was like, how can I do this better? And that required me to think a little bit outside of the box and just completely opt out of the system so that patients can get access to me as quickly as they needed it without any interference.
Thank you so much for telling us your story. I know for many specialists, the biggest question besides where do I start, how do I start, is how am I going to position myself? How do I know how to decide what my service will cost? And this is the most common question that I get from a lot of specialists, because when we get trained, we do not know this part of the business. And when we get outside and we are, actually attendings, we still don't know how much is our consultation valued. So my question will be, how did you decide your price for your services?
Pricing is probably one of the biggest conversations we need to have as physicians because it's relative. If you reach out to a lawyer, you may get one lawyer who charges 175 for their hour versus another who does a deposit and they withdraw from that account. So the way people price is highly individualized. What I decided to do was just to look amongst all of the service industries within my arena, in my community, and see how people were just charging for things. It ranged from physicians to lawyers to even contractors. How are people charging for stuff? And I kind of decided to choose an hourly rate rather than a bulk pricing system that insurance has instilled in us, right? So if you do a procedure, it comes with a code that comes at a value. And I hated that system because I'm very efficient. I can do something in 5 minutes versus another person who may take 30 minutes to numb up a toe, for example. So the value, patients don't see the value unless they've had a bad experience. And so I just decided, let's just keep it simple. And it's just going to be my time, what I want to charge. And I calculated what I wanted my salary to be up to the hour that it should be at. And so that's how I started to work with pricing. And then I started to move up from that. If there was more of a demand for what I did because it was very specialized, then the price would be a little bit higher. But if it was something that somebody else can easily do without further specialization, then I would try to be average, at least be average, but never looking at the insurance rate because the insurance pays you what people tolerate, not necessarily what can be valued.
Correct. I think that's an important point of view, because if you take their point of reference, it's most of the time it's going to undervalue your services. And from what I know, when I started, I had struggled with this question myself, and I was told different opinions by different people that I should start, let's say, 125% higher, or 100% higher than the price that Medicare will charge or will bill. You will bill to Medicare, basically. But as you said, it's a matter of the demand and what you can offer. And that's extremely, extremely powerful, wherever you are. And then your expectations as well. Now, the other question that I get a lot from specialists is, because we are by ourselves in an environment that it's not common. How do you market this kind of practice? How do you get out there and tell people about what you're doing and how you're doing it without, without making waves and people judging? And it's, you know how it is, different people, different opinions. But how do you get outside and how do you market your practice? How do you get outside the message?
Yeah, I think it's really important to understand that we can't control how people judge us. We can only show up to what we can offer, our value. So it's going to evolve for each physician who chooses direct care, because you might be initially in the position to try to convince someone to change their mind that we are valuable. But that is a completely wrong way to market yourself. You want to go out there and put yourself in a place where people are already looking for you. So people who have high deductibles are probably looking for better access that's more affordable, right? Or some people who don't have insurance, you just tell them, you just make a phone call. It's not complicated. And then you can be seen within 24 hours. So my marketing messages have evolved since I first started, because the only bubble that I knew was my referral sources who were in network. Those, as specialists, that's how we get our patients. And then I had to step outside of that and say, you know what, if I just directly market to the consumer, they might already be looking for me. So I might as well tell them exactly what I do and how to get there. That takes away all of the hassles. You're not going to get a phone tree. You're going to get a real person. You're not going to have to wait for 3 weeks or months. You can get an appointment within 24 hours. Things like that, things that people are looking for. So I had to create a message around that. The marketing scheme of things is still the same. We still have to do word of mouth, work with people who are aligned with our values, other cash practices, other businesses who want a better option for their employees, for example. So I still do community networking, and that could be through the Chamber of Commerce or BNI Business Association in your local networking. I also do social media marketing through Instagram and TikTok and YouTube videos. I also do Google Ads, because where do people go when they're looking for stuff? It's usually Google. And so if you have an ad that shows up, it makes you easier to reach. And then I also added on radio ads, because my ideal clients live on the radio. They're educated, they're involved in their own community. And so that's where I put my marketing dollars.
Excellent. And I'm sure you still have people with insurance that will reach out to you and they will say, do you take my insurance? How do you reply to that?
This too also evolves depending on your individual comfort level. For me, it definitely has. It started with a script that I got from another cash practice, and it was really long-winded, and that is just not my style. It was almost like a sales call. I mean, it is a sales call. You're trying to convince them this is the value if you chose us. But oftentimes for medical specialists, the game's a little bit different, because people assume all coverage is paid for by insurance. But we know preventive coverage is not covered. Innovative treatment options are not covered, right? So the conversation went from, I don't bill insurance so that I can spend more time with patients with you, and I can offer an appointment within 24 hours if that's what you're looking for. That's what I was saying today. What I used to say was the long-winded conversation of, what is it that you need? Do you know what our value is, what our benefits are to see us? And then halfway through the script, people would just hang up. They know they want what they want. They don't want to spend $1 with you. They were referred by their in-network doctor who thought that I was in-network, so they would get frustrated. And so what works for me may not necessarily work for others, but that's a conversation I'm starting to have now. It's a lot more clear as I get their intake information. What do you want to be seen for? And do you know that we don't bill insurance, which allows me to spend more time with you and offer you an appointment within 24 hours? That's kind of what I'm working with right now. And I'm sure it's going to evolve with time.
That's very, very, very good topic to discuss. And like you said, our message evolves. And that is because we understand the needs of the patient and how the patient perceives what we can offer. And I have to share with you that my message changed probably 10 times since I started. but it changed to address their fears and their concerns, because most of the time patients are concerned they are going to be billed like in an insurance scheme where they have to pay thousands of dollars. And I also ask patients if they went on my website and they check the prices, and I make sure that they know everything is transparent and also everything is what it is. It's no dollar extra or no hidden fees, because that's the biggest fear of patients, that they will be charged much, much more than what you say.
Yeah.
Now, I want you to tell me a story of one of your patients that you
Oh,
were
I
able
have
to
so
help.
many. I have so many. So my passion is in wound care, amputation prevention. And I had this older gentleman who first met me many years ago before I even had my private practice. I was in an employed situation and he followed me through my private practice. I saw him at the wound care center. He had gone through a lot of different physicians because at the wound care centers, there are different specialists. There are ER doctors, infectious disease doctors, vascular doctors, myself, podiatrist. A variety of us take part in wound care treatment. And he had gone through every individual doctor. And he had a lot of comorbidities. But unless you work with patients who have these comorbidities, you don't really know where they are at mentally. A lot of people excuse them for being non-compliant, difficult to work with, but ultimately it came down to him being afraid that because he was being transferred from one doctor to another, that nobody could truly help him. So he was functioning off of fear. And I had the good fortune of another doctor in the system who said, I think you can help this patient. Could you just do a consultation? And our first conversation was very confrontational. He was an older man who was like, how much experience do you have? Why would I trust you? Why are you the person people are recommending? So there was this friction between us already, first off the bat. But recognizing where he was coming from, that he was just deathly afraid of losing his leg because he had an uncle who also was amputated and then died, then I was able to engage with him a little bit more and say, well, what is it that you want? And have those deeper conversations that required more time than what we are traditionally offered, right? Patient interaction time matters. Being able to see a patient in 3 to 5 minutes at a wound care treatment center, it might work for some people, but it doesn't work for people like him. I needed to spend 30 minutes to an hour with him at each session because I had to gain his trust that I was indeed the best person for him for his work. And so when I decided to open my own practice and pivot out of insurance, I told him, I said, I'm cash only now. I have some great doctors I can refer you to if you wanted to use your insurance. But he was really adamant that I was the doctor for him. And so he stayed with me. And at the time, I wasn't really familiar with how to appropriately price. So I think that's a good conversation to have for a direct care specialist to know upfront what you should charge. But I just charged him whatever, at the time was whatever I thought was appropriate, what I thought was appropriate. But for him, it didn't matter. I provided a value. I was able to preserve his legs. He had all these wounds. They were gangrenous, they were infected, and so on. And he was able to pass away with his body parts still attached to him. And so I lived with this patient for 5 years. And the only way to achieve the result that he did was to have that relationship that was not being interfered by how people were going to get paid, how I was going to get paid, how he was going to get the care. And he's the first patient that I really recognized how valuable direct care was. Being able to just give him the care that he needed in the time that he needed, and being able to receive payment for that. Like it was just so simple and such a very challenging patient. And so that is one of my favorite stories to share, was having that relationship with him where he trusted me and I trusted him. And no matter what the outcome was, he got the care that he deserved.
It is very important to understand that in direct care, you develop this kind of deep, personalized approaches that you can offer to patients. And the relationship that you develop with patients is very, very deep. I have the same experience with my patients, and I know that many of us that are in direct primary care, they had the same type of relationships. And also in direct specialty care, I hear more and more physicians talking about rebuilding the trust and reconnecting truly with patients. Now, I know that you have put a lot of effort into educating other physicians in your field, and you actually founded a coaching program. And if I remember correctly, it's called Coaching with T. But you also are you also started a podcast called The Direct Care Way, where you actually educate specialists in your field, podiatrists, to walk away from the insurance environment and retrain their time, energy, and peace through direct care, as you say. Can you tell me more about this coaching program that you started?
Well, I want to thank you for being one of our special guests on the podcast. I think it's incredibly important to have a variety of specialists to kind of pitch in what worked for them so that we can decide what we want to do ultimately, right? Although I speak to podiatrists because that's my background, I do have other specialists reaching out just to get the framework of what it takes to develop a direct specialty care practice. So the podcast is really for all specialists because the way we design our practice is very unique compared to direct primary care, DPC model, where their model is predominantly membership based. And I've tried to kind of swing between a membership and fee for service, and I think every individual will decide what works best for them. And so I kind of put it all out there on the podcast for people to decide what's going to work for their specialty. So the podcast is really the conversations I've had with other specialists who had helped me develop my practice and some of the stuff that I learned along the way too, because there really isn't a manual on how to have these conversations, what to expect, how to deal with the constant fear that it's not going to work, it's going to fail. So I speak to it as if I was speaking to the younger version of myself, the information that I wish I knew to even ask. Because when you go into something new, you don't really even know what to ask until you're confronted with it. So it's kind of a preparatory phase for anyone looking to direct care. My coaching program is just a supplement. A lot of us are very self-driven. We can research things on our own. And so it's just kind of there as a complementary service. I know a lot of us can achieve a successful practice very well on our own, but if the words that I'm saying resonates with other podiatrists or specialists, then I'm here for you as well. Because sometimes we need that one-to-one interaction to really get focused on what we want to achieve in our practice. And so the coaching program does offer that one-on-one call or group coaching call that I've done previously. Plus, we learn better when we have somebody to interact with rather than a self-paced module. However, I do have a self-paced module that answers all of the regular questions, the most frequently asked questions, and I do it in a way that makes sense to the person who is looking into direct care. So I have a 12-week course called Launch in 12 Weeks for anyone interested in going into direct care. And it addresses questions that you ask here, like how do I price things? How do I define my ideal client? Why I need to define my ideal client, and all of those things, all in 12 weeks. So I have a lot of different resources and it's all put into one place. So you're not having to thumb through a bunch of different resources. It's all conveniently in one place, totally affordable. It's kind of silly how much it costs right now, but take advantage of that if that's something you want to do.
Thank you. We have some people here, and I will invite them to ask questions to be specific to their needs, and we will try to answer whatever questions you have. You can leave a question in the chat, or you can also join us and ask the question.
I'm going to call you out, Sandama and Nam. I know you. How can I help you in the next stage in your practice? Maybe that would be a better question. Because we don't know what we don't know, right?
I have a question, T. So
yeah.
I'm a newly started direct care practice, and I had to start it relatively quickly, so within a span of 4 weeks. So because I started it so quickly in terms of office space, I don't have an official office space. I rent out a space, but the price is extremely expensive, and it's far outside of Dallas, where I mainly market and practice. The one thing that I've been having a hard time doing is getting patients to feel comfortable doing a house call, because I find that a lot of patients actually prefer to see you at an office as opposed to on a mobile house call basis, because I was trying to capture that market first. But I'm finding that a lot of them want to go into an official office.
Mm-hmm.
Just wondering if you had any experience with that same problem or that same barrier of patients always wanting to go into office as opposed to a mobile basis.
So are you wanting to be mobile? I heard you had an office, but you want to be mobile. Is that right?
No, no. So I actually I'm on the search for an office in the Dallas area. Um,
Mm-hmm.
but it takes time to find an office and to get all the leases signed. But in the
Mm-hmm.
meantime, I'm offering mobile services to the patients.
Okay, to get
But
started, right?
to get started, exactly.
Got it. Okay, so what I understand from your question is how do I get money? How do I get started? How do I get patients, right?
Oh
Not
no,
necessarily mobile.
I'm just wondering if you had any experience with patients not feeling comfortable with the doctor coming into their house.
Oh yeah.
Um, yeah.
Yeah. Okay. What you want to think about is who are you trying to serve? Who actually wants the home mobile clinic? It's not going to be the 30-year-old. It's probably not going to be the 50-year-old. It's probably going to be the geriatric population. The geriatric population or a busy business executive, people who just value their time and don't want to leave their bubble, their space. So you have to know who you're serving before you even start talking about marketing. So if you decide, I want to work with geriatric patients because they need the mobile care clinic, that's where you start, right? Realizing that those are the people you need to market to. So do you think that is a possibility in your practice for you to serve older people who can't leave the house?
Yeah, I definitely think that that's a good portion of the Dallas population. The only thing that's conflicting with my practice is I've tried to niche down the practice in order to provide a good value proposition to patients. And the niche is non-invasive and minimally invasive treatment of the foot and ankle.
Yeah, so I've been in the same situation you were just a couple of years ago. And what you'll realize is people don't come to you because you do surgery. They come to you because you have a relationship with them. So despite what others might have taught you that people come to you for surgery, I find that to be a huge contradiction because people don't just trust you automatically to do surgery on them. You have to have a relationship first. And you may need to develop that relationship by maybe a televisit, consultation by phone. They may not even understand what MIS is. They're like, why do I need to go to you when I can just go to somebody in network, right? And so there's a strategy to refining your message that isn't so, it's a little abrasive to tell people I do surgery, come to me. Because that's how we're taught. We're like, we have the technique, but we haven't built that bridge to connect with patients, to build that trust, to make them know that we are the person for them to go to, especially if we haven't been established yet. Does that make sense? So people aren't going to come to you because you are MIS. People come to you because they know you, they trust your work, they see the outcome. You've built a rapport with people in your community that can vouch for you. Otherwise, you're kind of just another face on google.com, right? Or another face to compare to with an in-network person. So right now, the public perceives us as equivalent to in-network. And that is going to take about 2 to 3 years of maturity to put your roots down where people hear about you over and over again to finally trust you to be the go-to person for this surgery. I hope that makes sense.
It does.
Yeah, so it's not like people are just going to automatically come in your way and say, you do MIS, I want this thing. They don't know what they want. We have to walk them there. They don't know that there's a difference with MIS versus traditional. Only the most absolute savvy of people know that, and that is a very small population. What you want to do is open up your net and say, I offer consultations by video, or I can come to you. We'll have this conversation. They pay you for that consultation. You educate them that, oh, it sounds like you need a hammer toe surgery. Have you considered MIS? Do you know what that looks like? Do you know that I'm the only one in this community that does that because of the benefits X, Y, and Z? Do you see where I'm going with that? You're building a relationship.
Yes. And then these telehealth, have you ever offered free consultations via telehealth, or is it always paid for your time?
I think the niche that we have is so special that nobody knows about it. You have to be able to be free with your time for at least 15 minutes just to gauge if they're even a good fit. So I don't know, Diana, do you do that? I do that.
I've done that in the past. It's a 15 minutes meet and greet call. You can open up the calendar and set up a couple of those every day. And they can book the time and you can jump on the call and hear some of their story. And you can say, yes, I can help you. You know, that's what you have to say, that they're looking for someone to see if they can get help. And you can say, yes, I can help you with that. And I have options for you. And then you can continue with, you need to book an appointment where we will sit down for an hour. We'll have a conversation and I'll give you all the options. So you basically have to build up trust, as T said. It's extremely important when you start to build up trust with others. And regarding, an office, I know you are doing surgery, so you have to have an office that probably is set up for surgery, but you can, you can talk to one of the practices that are in your community to give you the space. They usually have a space that basically they don't use all the time, or you can just say, I'll pay you every single time when I have to come here, and I'll let you know 24 hours in advance. It's a little bit of a struggle, but especially when you don't have patients, it's important for you to have access to a place and don't pay for a whole office all the time, because that might not be feasible in the first 6 months.
Yeah, and I think that's what's going on right now. So I actually have a patient booked for surgery in the next 2 weeks. And we have all the payment for the surgery and the facility and the anesthesia fee all figured out. The only thing is all the post-op visits are included in the surgery following 90 days. And each of those visits will have to be booked in an office that I pay on a as-needed basis. But the more post-op visits that the patient has with me, obviously it erodes into the actual revenue of the initial payment.
But actually, some of the visits, you can do that through telemedicine. You don't have to see the patient every single time in person, right?
Correct, yeah. So the initial post-op visit is usually in person, just because we need to take out the stitches, but the following ones, we can probably do some of those on telemedicine.
Sure. We have somebody else here, and maybe you have a question?
If not, I'll kind of elaborate on your point, Nam. There are a lot of primary care doctors who don't use their office space full time. You just need a room. There are physical therapists that might be a good partner, chiropractor, acupuncture, naturopath. These are people who don't work full time and have office space and often will sublease. So if you make friends and say, hey, is it cool if I come, maybe an hour a week or something just to take care of a patient? That could be free for you if you can do a trade and it's not legally binding. You're not giving them the benefit. I don't know how the state of Texas work, but in California, you have to be careful about how you sublease, that it doesn't look like there's a kickback or something. But you can just say, can I just do a quick follow-up? And then they might be a referral source for you for the aftercare. So look at community relationships in that way that benefits you both. Or maybe even I'm a little bit edgy about when it comes to other podiatrists, sharing office space with other podiatrists, but maybe you have a really good relationship with somebody and say, hey, can I just, as I'm picking things up, can I use your office space while you're not there? And some people might be open to that.
Yeah, I think I asked another podiatrist and he was kind of caught off guard and almost got a little bit territorial
Most
about
will, yeah.
it. Yeah, and I understood, having another podiatrist coming in and as they can see it as competition.
Yeah, that's why I think physical therapists, they have huge space, and if they're not there, just you're gonna have to, I think you need my consulting program. I'm just gonna say there's a lot to work through here. So keep an open mind. I'm here for you.
Sounds good. Thank you.
You're welcome. All right, let
Thank
me
you.
see. How do I unmute you?
Oh, I got it.
You got
I
it.
got you. Okay,
Yep.
you got it. Okay.
I figured it out.
Hey,
Tell us
Hi.
how do we pronounce your name and where are you joining us from?
Hi, my name is Sandama. I am in Phoenix, Arizona.
Woohoo! Great.
Yeah.
Yes. So I guess one of my big questions would be, to T especially, how do you feel about companies? I've heard especially primary care doctors talking about this a lot, kind of like the in-office dispensing companies for different medications, antibiotics that are commonly used, things like that. How do you feel about those type of things? Do you think that patients can potentially benefit from them? It's not something that I guess I'm looking to do immediately right now because I'm still in very new stage. I'm opening next month, but maybe in the next year, 2 years, 3 years down the line when I'm in a larger space.
What is your specialty?
Podiatry. Yeah, I'm
Good.
a podiatrist as well.
the medications that I prescribe is Keflex, maybe Jublia, maybe Lamisil. Like I have like 3 things I prescribe, maybe Norco even, right? It doesn't make sense for me to add on the stress of inventory, expenses, cost to offer that in my office. Our advantage is most people expect us to write it out. So I don't think that is going to be terribly valuable for my situation. So you have to decide how much are you going to prescribe and is it really unique? Like, or can they just go down to the pharmacy? So for me, I don't think it's worth it. I know rheumatology prescribes a lot of different medications, might be different for you. I don't know. But no, I don't think it's any value to me at this point.
I have to agree. You just have to decide if that will bring you something extra. And there are some states that does not allow you to prescribe or not to prescribe. They don't allow you to dispense medication from your office. I don't know your state rules, regulations, but and I know that some states, they do require you to have an extra certification to even keep those medications in your office. So you just have to decide along the way if that is of value for your practice or for your patients. But start, get patients, get on the go, and then you can add other things in time to provide more and more value to your patients. That's my advice.
Thank you.
I like what you said. Start with your patients because your patients will tell you what you need. You don't decide. Yeah.
Most of the time we think patients need this or that. And I have to tell you that even myself in the beginning, I had a long list of things that I need.
Yeah.
And eventually I did not need it. Probably 10-20% of the things that I was thinking I'm going to need because you don't use them, and don't buy them if you don't use them.
Oh my God, I have to agree.
Buy them when you use it. Just wait to see what are the needs of your patients, and then you invest in that kind of proposition, the one that is made by patients, not by us, because we tend to think that they need more than that they need.
Let me tell you, I opened my practice in 2018. I still have cast material that have not been touched. You don't need all the things. You just need the things for 1 month's worth. Trust me.
We have,
Fortunately, our patients are really wonderful. They're very understanding if we don't have stuff in stock. We're like, oh, you know what? We just ran out. Can I get it for you next week? No big deal. Not a big deal.
oh, that's
We
great.
got
Yeah,
somebody new.
we have somebody else. Prasanti, you have to unmute and ask us a question.
Hi, I
Can
just
be trained.
joined.
Tell us where you are joining us from and what's your specialty.
So I'm an endocrinologist in Dallas.
Welcome.
Thank you.
Oh, hey, you'll know that there's two podiatrists here. We have one podiatrist, Nam, who's in Texas, a little out of Dallas, so maybe you guys can connect.
Yes, I was trying to connect with people. I have talked to few people now. I have stopped taking few insurances, HMO. Slowly, I'm trying to see if I can do the direct care. I didn't like completely, stop all the insurances. Still, I feel like it's I have to do a lot of things on the concerns and rebuild my website because I am private practice solo physician. So until now, I have been doing the regular, private practice, but slowly I do want to switch to direct care. Right now, I do see few patients for cash pay, but not a whole lot.
So in our first roundtable, we actually talked about hybrid versus direct care. And me and T, we share our thoughts about that. And I highly encourage you to reach out on the YouTube channel. I put it there, but you also have it in the Specialist for Direct Care group. And
okay, that would be good. Yeah.
Yes, you find a lot from our insight there.
Mm-hmm.
And on the Direct Specialty Care Alliance website, people that are members, they have access to an online course to educate them about direct care and about the switch and about the things that they should consider. So you are welcome to check that out. And we also have another person here, SG. I don't know who they are. Maybe you can
Prasanti,
introduce
before
yourself.
I let you go, do you have any specific questions you
want
us to answer?
So main thing is, like how do you, I kind of know, but main thing is like putting the forms together, or do you revamp the whole thing, like, rebuild your website or redo everything, or all just modify a little bit on the consent forms? How do you all do it little by little, or, suddenly change everything?
I went through a lawyer, which costed me more than I needed to do. You just tell, like on your consent that says we don't bill insurance. That's all you have to do. And if you don't have a membership, that's all you need to do. But if you have a membership in a state that might be direct care unfriendly, then you need to get a lawyer that says my membership does not constitute an insurance plan.
Got it. Okay. So you have to go through the lawyer. And do you all use like I'm not sure which states, but through your state medical board lawyers or something like that, or just private? Okay.
You have to find a private lawyer. And if you are a member of the DSA Alliance, I usually provide those services for all the members. We connect you with the right people, because that was a huge drawback when I started, and I didn't know who I should reach out, who knows the information, because a lot of times you're going to find out that people will say that they know, and then you figure out that they don't know what you are talking about, especially when it comes to direct care. Not a lot of healthcare lawyers have an idea about direct care. And when you start with direct care, if you are contracted with certain insurances and your patient has that insurance, but you have contract with that insurance, you cannot offer the cash to them because you are contracted with his or her insurance. But if you're not contracted with that insurance, you can, basically offer the cash price. The private insurances are less strict, but if there is a patient with Medicare, that's a problem. That could be considered fraud, and you could be liable for that. And you don't want that. You definitely do not want to take money. If you are opt-in Medicare, you don't want to take money from someone that has Medicare.
Oh, so that's very good to know, because I was not sure. So I still see Medicare. I am not opted out. But then I said we are closed for new Medicare. So
yes, but you cannot take money from
money from
patients
Medicare.
that are part of Medicare. It's
Okay,
illegal.
so I cannot do cash price for Medicare. Okay,
You
that's
cannot.
very good to know. Thank you so much. And then you said DSC Alliance for looking for the forms or anything?
Yes, dscalliance.org is the website, and you can join us, and then you get access to all of these resources.
Okay.
And we help
that
you.
would be
I mean, that's the reason of this DSC Alliance, to empower physicians like you that are interested in direct care to make the transition. Everyone is different. Everyone's expectation is different. So we offer you the resources, and you talk to the lawyer. You tell them your specific situation, because the laws for direct care vary from state to state.
Yes.
Too. So you have to know about that, and you have to find someone that is knowledgeable in direct care in your state.
That's right. Yeah, that's right. Thank you so much.
You're very welcome. We have somebody else here. SG, you have to introduce yourself and tell us what specialty.
Yes. Hi there.
Are you coming from? And where are you coming from?
So I'm in Jersey, and I think I've been in touch with T over Facebook Messenger several months ago when I was starting my practice. So I'm a neurologist, and I opened my own practice a little over a year ago. And and that's when I got into all of these Facebook groups, private practice physicians and direct care, care physicians, and all of this. So I am a big. So prior to hold on a second. I'm in the hospital now on call, so people are sent to voicemail. Okay, all right. So prior to this, I was hospital employed, and so I moved to having my own practice, and I have witnessed firsthand how frustrating it is to deal with insurance companies and getting in network and all of that. And so, yes, the idea of direct care was very appealing. I think it is sort of, I mean, of course, yes, that would be the ideal world. But I think that it's very hard to recruit patients if you're not taking insurance. And I mean, they might see you for one visit or two visits if you have like raving reviews and they really want to get your opinion. So for a specialty like neurology, it's hard. Like they would come for once or twice, but it's hard for them to continue their care with just direct pay. So I think it's just harder to pull that off and support a family with this. I mean, unless you have like a side income, which is pretty solid. And so you're like, okay, I'm going to have this and I'm going to build this over time. Then I think it's a good strategy. Or if you have been in network with insurance for like several years and you have a very loyal following of patients who will continue, like a proportion of which will continue with you for direct care, then I think it's a different issue. I mean, I think you'll still probably be left with 30% of your existing panel. You probably are going to. So that is what I was. But I'm still like, I every now and then I try to see if there's anything new in direct care. But at this point, my only, the hesitation is that although I would love to not have to deal with insurance companies, it's just hard to practice medicine doing direct pay in this country.
I have to argue with that.
You will have two opinions here. One from someone that worked with insurance companies when she started private practice. So Dr. T, she did work with insurance companies and then she transitioned to direct care. And then you will have my opinion that jump into direct care straight out of employee position. So Dr. T.
Oh, there's so much to unravel here because we all think, believe, and drink the juice that says we can't function without insurance. That's how we were trained, right? And you're kind of right. But you're also missing a whole population of people who you can serve. How long does it take a patient to see a neurologist in the traditional setting? Can they be seen within 24 hours?
I'm sorry, what?
Can a patient be seen within 24 hours a neurologist? Can they see somebody
Yeah.
that fast?
Hard, yeah. So that's hard to do.
Right. So that's one of your value propositions as a direct care specialist, right? So just think about the pockets of need that is missing. What about people who don't have insurance that need neurology care? Can you serve them?
Right, but I missed out one point. So before when I started my practice, I was not in network with a lot of insurance panels because the application was still in process. So it took like 6 to 7 months to actually get in network with a lot of panels. So prior to that, it was all cash pay essentially. But my schedule used to be like maybe 3 or 4 patients a week, maybe even less. Like they would cancel last minute. So it was very hard to have like, and we were able to offer same day appointments, or like they would call and come in. So it was very hard to like recruit patients in that first 6 7 months when we were doing. Now I will admit there were like I think a few, we were not advertising ourselves as direct care. Well, we were not like going out of the way to like, we would just say that we are waiting to get a network with insurances, but you can see us as direct pay. Also, I think we did not have as many reviews and all of that at that time because it was just the beginning of our practice. So I think now it's a different situation. But even now, like it's very yeah, it had, I don't know, it was very hard to be able to see patients. And the other thing was we were trying to offer where we would check patients out of network benefits, and then we would submit the claim ourselves, and it became very very frustrating because a lot of times we would not get paid, or there would be a delay in payment and whatnot. So I don't know how you guys deal with that part. Like, do you submit do you submit the claims yourself, or do you just have the patient submit it?
I think
Yes.
I think what I want to add, really, all of these details are important, but I think at the end of the day, you have to decide what it means to be a business owner. If you think being a business owner means opening your door and people are just going to come in, that's a guaranteed way to fail. But a business owner is very proactive. We have to tell people that we exist. When your insurance it's easier. You're in network, you get referrals. When you own your practice and you're doing something wildly different, you have to learn how to be a business owner. You have to tell people, I do this thing that you want. This is how you access me. And you have to do that every day. So there is a lot of work in direct care, and that's how we make it work. It's not passive energy at all. And so you have to decide, do you want to spend your energy to develop that CEO skill set, or do you prefer the insurance way? And it's not wrong. It's just whatever you want to focus on. And a lot of people decide to stay in insurance, fine. Some people do a hybrid, great. Some people do cash. It's all there for you, but you have to decide which direction you want to take.
Right. Yeah.
You should reach out to me because I can, teach you, put you in some contacts with some people to teach you how to advertise your practice the right way, because that's another thing. You send out the wrong message. You kind of confuse patients. We do this, but we're going to do that. So that's very, very confusing for patients. And you change their expectations right at the beginning. You give them something, but you tell them that there is something else coming, okay? And I agree, for specialists is not so easy as it is for, and I don't think it's easy also for direct primary care, but the value proposition that they offer, we take care of you, every single, problem that you have, we can handle that to a certain point, is different from what you offer as a specialist. So, and if you are super specialized, let's say in migraines or whatever you are, go on that niche. Invest in that. You are the expert in that, and show it to patients to see. And then, it might be hard in the first 6 months. Nobody says this is the ideal world. Nobody ever said that. And I don't want people to believe that this is the ideal world and the other world, the insurance world, is the worst world. No, it can work for some people, and it cannot work for others. So, like T said, you have to proactively do things to put yourself in front of the patient. And yes, it might take 6 months. Yes, it might take 1 year, but you will succeed if you pursue one message that can be altered, can be, I would say, refined, but you have to have that streamlined message out there, which I think
Right.
in your case was not.
Right. It is possible, very much. Yeah. Okay. No, and by the way, I greatly appreciate you guys like trying to like, lead this bandwagon on, direct care. This is really admirable. And I really hope that this grows and this becomes more people opt for this. One thing that I strongly believe is that it's important for physicians to have all of these options that work,
Correct.
because otherwise the only option that's going to be left is being employed. And then if the administrators know that you don't have an alternative option, you're going to be taken advantage of. So it's good for it is good for every physician, but whether they're academic or non-academic, employed or not employed, for all of these avenues to thrive, so that they are not being taken advantage of when they work for someone, because they know they can leave.
What I can
You're
tell,
totally right.
I tell other physicians that this is an option. It's
Yeah.
not the only option.
Right.
And we are not fighting against the system. We
Right.
are searching for options for those of us that love medicine and love our patients and love practicing medicine. Because there are, only last year, there were 100,000 physicians that left medicine forever.
Right.
So who's going to take care of us? Okay.
Sure.
We
Yeah.
all gonna become patients. We need our peers to remain. They invested time and effort in their education and, time that will never come back. Why would you leave that?
Yeah. Yeah. Absolutely.
For the sake of time, we want to thank Dr. T. Nguyen here for giving us the insights, and we want to thank you also for joining us. And we would love to have you in the next sessions also. Dr. T, anything that you want to leave with the audience before we close the session?
These are really important conversations to have, because a lot of us sit in conflict because we're not sure of life outside of insurance. But I think we have to really disengage momentarily and decide what we want 10 years from now, and see what that person will be doing looking back. But a lot of the times we kind of sit in indifference, maybe fear, maybe, there's just too much going on, and so on. And so I think the best thing you can do for yourself is to find a specialist who's doing what you're doing and just live in their brain space for the next year or two. And that way you're in the right place. Because if you're in the wrong company all day long, then yeah, it's going to be impossible. So pick your company wisely is what I would say with that. Well, thanks so much for coming. Maybe I'll catch you guys next time. DM me anytime. Let me know how I can help. Have a good one.
Thank you, guys.
Right.
Bye-bye.
Bye.